नीरव, टेक टीम आईटी आपके आरएक्स इवेंट से है?
यस सर।
ओके ओके।
सर, माई सेल्फ खुशहाल, मैं आज का वेबिनार मैं देख रहा हूँ सर।
अच्छा कुशल, ठीक है।
हाँ।
evening. I'm Dr. Ajinkya Nanavare from Emcure Pharmaceuticals. I welcome everyone to yet another session of the No Thrombosis workshop in acute ischemic stroke. And in the previous workshops, we had very unique and interesting case discussions, and we are looking forward to have a fruitful and important discussion today as well. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and gain insights from the moderators and the wisdom shared by our course director. And it is my honor to introduce our faculty for today. Let me share my screen. So I first welcome Dr. Ichapuria sir. Sir is Director Neurology at Sahyadri Hospital, Pune. Sir has the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. Sir has more than 300 public lectures and workshops on stroke. Sir has been a member of Indian Stroke Association, the organizing president of StrokeCon 2012 and ISH Stroke Cool. Sir has been a founder of Pune Stroke Group and ex-president of Society of Neurosciences Pune and Maharashtra Academy of Neurology. He has been principal investigator for many multinational stroke trials like Perform, BrainsGate, etc. And he has been awarded as health icon by the Times of India group recently. Welcome Ichapuria sir to the workshop.
Thank you. Thank you for the kind words.
Then I welcome our first moderator, Dr. Anshu Rodgi sir. Sir is consultant neurologist at Sir Gangaram Hospital, New Delhi, and professor of neurology at Gangaram Institute of Postgraduate Medicine and Research. He is a secretary at Delhi Neurological Association from 2021 and onwards, joint secretary at Association of Neurologists in Clinical Research, Mumbai, coordinator at IBS and ICU of Neurology, and principal investigator for more than 24 studies like Vitatope, Profets, etc. Sir has more than 47 publications in various reputed national and international journals, also presented more than 25 scientific papers at various conferences. He has been guest faculty at many prestigious neurological meetings and conferences. Welcome, Dr. Anshu Rodgi, sir.
Thank you, Dr. Jain. Kind introduction.
Yeah. Then I welcome Dr. Tarun Nagpal, sir. Sir, I think he could not join due to some family emergency. He is a director at Aditya Super Speciality Hospital and Trauma Center, Jabalpur. He has interest in cerebrovascular disorders and started the stroke thrombolysis program in MP in 2009. He also has to his credit the first plasma exchange for Hashimoto's encephalopathy in India and interest in sleep disorders and conducting sleep studies for the neurological conditions, a level 1 sleep lab setup. He has been associate editor for Annals of Indian Academy of Neurology for last 2 years. Then I welcome our first expert speaker for tonight, Dr. Venkatesh Bolegave, sir. Sir is consultant neurologist at Prakriti Hospital, Thane. Sir has multiple publications in various national and international journals and multiple poster and paper presentations at various conferences. He has won multiple prizes at conferences like first prize in National Conference on Headache, Cochin, and third prize in National Neurology Quiz at Shine Conference, Chennai. Welcome, Dr. Venkatesh, sir, to this workshop. Then I welcome our second expert speaker for tonight, Dr. Anuj Nahete, sir. Sir is consultant neurologist at KRH Hospital, Nashik. He has over 7 publications in national and international journals. He has also attended the Nieman's posting for 3 months and interested in teaching students and research projects. He has also won multiple prizes in quiz competitions like second prize in Arpan National Nieman's Quiz in 2018. Welcome, Dr. Anuj, to this session. With this short introduction of all faculty members, I would like to hand over this session to Dr. Ichapuria, sir, our course director for tonight, for context setting and his opening comments. Dr. Ichapuria, sir, over to you.
Yeah, thank you, Dr. Ajinkya. I think we have finished 1 year of this No Thrombosis national workshop, and yes. It's been really very interesting. and very thought-provoking and, continuous learning for all of us. And Dr. Anshu Rodgi is also been on this program many times, and I'm sure he will echo the same sentiments. And Dr. Venkatesh, I think, is coming here for the third time, and he's been here twice before, and he's presented two wonderful cases which we really enjoyed. So I think he's also enjoying himself coming here, and therefore he's coming here now for the third time. And I think we've had some outstanding cases, some cases which we've never seen before, and many, many things to learn. And I think it's been also a very popular program all over India. And we've had quite a interested audience, and I'm sure they've also benefited by this program. So I will ask now Dr. Anshu to say a few words before we start out. Who's starting first?
Dr. Venkatesh sir can start.
Venkatesh is it. Anshu, can you say a few words before we start?
Yeah.
Not clear.
Yeah.
Anshu sir, you can stop your video and then speak. I think your network is low.
Thank you. I think this is a very, very unique program because I think what I'm saying in another. So I think I would echo what Dr. Ikshapuri has said, and it's really a learning experience for us also. And so I think we can start today's evening program. I think Dr. Venkatesh will present first.
Yes.
Okay. Please go ahead.
So my screen is visible?
Yes, sir. You can switch to full screen mode. Slideshow. Yeah.
Okay. So I'm audible clearly?
Yes, you are audible and visible both.
Okay. Thank you. So good evening all. Today I will be presenting an unusual scenario, a simple case, straightforward. This is a 47-year-old male who presented with acute onset of left hem paresis and dysarthria of 2 hours duration. So it is acute stroke within window period. He presented to us. History-wise, he was non-diabetic, non-hypertensive. There was no history of consumption of tobacco or alcohol or any family history of cardiac or CNS events. The vitals were stable. Blood pressure was around 130. Blood sugars were within normal range and saturation was okay. So this is the patient video at admission. So patient is conscious. Dense semiparesis. So you can see there is no movement in the left upper limb or lower limb. Power is 0. Plantar's mu. So that was the clinical presentation. So urgent CT was done. This is a patient in nursing home. So only CT brain plane was available, which was done at night. And as we can see, there is no bleed. And this is a zoom photo. We can see on the right side, we can see that there is loss of gray-white differentiation here cortically. So it will be a large cortical infarct, which is seen early in the course. So the patient's NIHS was 14/42, and it is a moderate stroke. So with this unstable vitals and no obvious contraindication, history-wise, we went ahead with thrombolysis. So weight was approximately 70 kg, hence thrombolized with tenecteplase 17 milligram. This is after 12 hours. This was in the morning. There is slight movement of the fingers. Just he is now able to move sideways a bit. So in the morning, this was the slight improvement. And after 24 hours, he is able to lift the leg above bed, even the left upper limb, he is able to move against gravity. So there was improvement which was coming up, and relatives, etc., were happy. So we went ahead with MR angiography, and this was the MR angiography brain diffusion weighted image on the left side. We can see a cortical infarct. Much of the territory is preserved, but there is also bleeding which has occurred in the PC territory region. Angio-wise, it was clear. There was no obvious major vessel occlusion which was seen. So with this, we were okay, and we have started low-dose antiplatelets. But then when we went ahead with the further investigations, 2D echo, we found obviously it was, since there was no obvious history of diabetes or other risk factors, there was suspicion that 2D echo will show something. And though there is no history of any cardiac thing like dyspnea on exertion, chest pain, etc., he underwent 2D echo, and we can see this is mitral leaflet, and there is some floating attached mass here we can see. And here these are mitral leaflets which are thickened. And here we can see a mitral regurgitation which was obviously seen. So there was a 16/7 soft, elongated, fragile moving echogenic structure which was attached to posterior mitral valve leaflet, which was pointing towards some vegetation, and there was a suspicion of infective endocarditis. And retrospectively, we asked, there was no history of any drug abuse or any history of fever. Even we watched for any peripheral markers of infective endocarditis, there were not there. So we went ahead with blood cultures, and all the 3 blood cultures were negative. Even now the COVID is reappearing, so we thought of, along with COVID and S3 and 2, it was also sent, and it turned out to be negative. But he deteriorated very fast. He became breathless. His hemoglobin had dropped. Neurologically, he remained okay. Creat had shot up, and he was not maintaining saturation, hence was intubated. But because of sudden worsening, we lost the patient on around day 4. So that was the case. There was suddenly unusual finding of cardiac involvement in the form of some vegetation, most likely because of infective endocarditis, without any obvious history of fever or any suspicion beforehand, before giving thrombolysis, to say there was any cardiac anomaly was there. So what literature says, obviously there is patients with infective endocarditis are not recommended for thrombolytic therapy in acute ischemic stroke. This is 2016. So there are obviously case reports. This is a case report which into 2020. Intravenous thrombolysis in acute ischemic stroke patient with unsuspected infective endocarditis. They have studied, number is large, it was around 1,000 patients, 1,022. And only about 5 patients they have found that there was diagnosis of infective endocarditis, and of which the most important thing was fever was only in 1 patient of all of them. So it is very difficult to initially suspect on just clinical history of infective endocarditis. And obviously there is, since we don't know, many patients have been thrombolized, but they have not done well. So our patient was also obviously has not done well, which goes with literature. So patient with infective endocarditis, either because of cardiac status or because of bleed, they bleed after thrombolysis and they don't do well. So what can be done for such patients if we come to know, if sometimes patients are already diagnosed and they get stroke, or sometimes if facilities are available in hospital of 2D echo in the ICU setup, then such patient can be screened immediately. And if we find there is some suspicion of infective endocarditis, then such patients have can undergo mechanical thrombectomy if major vessel occlusion is found. Though there is, the quality of evidence is low, but this has been recommended. What the take-home message from this case is, the incidence of stroke in patient with infective endocarditis is approximately 10% and can result either from embolic or hemorrhagic event. Approximately 35% of patients with infective endocarditis are symptomatic cerebrovascular complication, and as many as 80% of patients have incidence of stroke on imaging. The available limited data suggests that neither anticoagulation therapy nor aspirin reduces the embolic events in patients with infective endocarditis. Therefore, anticoagulation or antiplatelet is not indicated to reduce the thromboembolic risk. In most patients with infective endocarditis on anticoagulation who develop acute ischemia, we suggest discontinuation of anticoagulation therapy for at least 2 weeks. And infective endocarditis rated stroke with mortality as high as 75%, those who receive thrombolysis. So this was the case. So I have come to the end of my case. Straightforward but an unusual scenario, and most of the patient initially, though they recover from thrombolysis, but either they eventually succumb to cardiac or neurological complication. Thank you.
Yeah. Anshu, would you like to say something?
I think sir has lost the connection.
Okay. Okay. So, but Venkatesh,
Yes, sir.
how are we sure that it is infective endocarditis?
Yes, sir. There was not surety. There was suspicion on 2D echocardiography of infective endocarditis because there
were
is
negative
visitation.
And there was no fever.
Right, sir.
So, can it be anything else?
I have discussed with 2-3 cardiologists, sir, with the same 2D echo report.
Yeah.
And these images. So they were saying that possibility of infective endocarditis can't be ruled out. We were planning for other.
Can't be ruled out.
Can't be ruled out.
But there is no evidence. I mean,
no obvious
there was
evidence.
No fever, and the 3 blood cultures without antibiotics were negative.
In this case, sir,
that
antibiotics
seems
were started. Generally, monosafe we start.
So can it be something else?
The first DD from all the 3 cardiologists was possibility of infective endocarditis, sir.
No, it may be, but can it be something else? Because, we had a similar case like that, and it was Libman-Sachs endocarditis.
Okay.
And the person had malignancy.
Possible.
So, this Libman-Sachs endocarditis can present like this.
Yes, possible.
Another thing, now we say that cancer-associated infarcts should be in 3 vessels.
Yes.
But, if there's one major vessel which is involved, it may come over a period of time.
True.
So, in this case, maybe if you do the coagulation workup, especially, what did we do in that case? This FDP, that is very typical of cancer-induced coagulopathy. So, I would think of cancer associated. Other thing, without fever, think of atrial myxoma, which is there on the valve. So you have to keep this thing wide
Open.
and so there can be myxoma, there can be a thrombus, there could have been because there's mitral regurgitation. Maybe mitral regurgitation was because of the endocarditis, or it could be native also. So some other clot there or something, so we must keep our thing wide.
Right.
So yes, in infective endocarditis, IV thrombolysis is contraindicated. And recently we had a case, young boy of 14 years who came with an acute stroke, and there was a occlusion of the middle cerebral artery on CT angio. But he had fever for 3-4 days, not 3-4 days, 2-3 weeks prior to the stroke. And we did thrombectomy. So another thing in this case you could have done is you could have done a CT angio at the first time, and the infarct was big, aspect score appears to be low, and NIHSS was also 14. So the thrombectomy in these cases, would be preferable.
Yes.
As that article by Dr. Ferro also has shown. And we did a thrombectomy in that case, and he improved completely. He walked home. And then later on, his aortic valve, there was a vegetation on that. So we had to do aortic valve replacement because he had LVF due to aortic regurgitation. And after doing that heart surgery also, he improved completely. And that was a case of brucella. So we could isolate brucella in the blood, and his brucella IgM and IgG were also positive. It was brucella millicentis. So infective endocarditis, I think the treatment, though there are very few studies, we presented this case in a stroke conference, and nobody had done thrombectomy in a 14-year-old boy with infective endocarditis. So in this case, I would think that first, when there is such a large stroke, you should do a CT angio and see if there is any large vessel occlusion. And if there is a large vessel occlusion, then of course, mechanical thrombectomy is indicated. Usually we give IV thrombolysis prior to that. And that time you didn't know that, and we don't do echo immediately. We do echo later on. So I think that part of your treatment is correct. But I would have taken it to one more step and done a CT angio and shown that if there is a large vessel occlusion. Other thing, I think, you should have also looked for malignancy. And, there was very rapid deterioration. Deterioration. Now, what was the cause of the deterioration? Was he throwing emboli, or
no, sir. Neurologically,
he
didn't worsen.
What?
Neurologically, he didn't worsen. He became breathless.
Yeah. But why did he worsen medically? Why did he worsen? He developed LVF because of the mitral regurg.
Yes, sir.
So, or he developed something else, some systemic thing. Even though he worsened, there was no fever, as you said. So,
yes.
So some fulminant malignancy, or because of the mitral regurg, he worsened rapidly. That is also a possibility.
Yes.
So. I think little more investigation. In this case. Maybe, as you said, he was in a small nursing home, so it was not possible to do everything. Other thing in that video you showed, and which I object to, is pinching the patient.
Actually, they were.
Yeah, even if that houseman is there, we should not pinch the patient.
Right.
See, pinching the leg and pinching the hand. No, because see, by pinching, first of all, it is it's
Response.
not good for the patient. It looks shabby. And also, you may get a spinal reflex because of pinching. So the leg may move and you'll say, no, power is grade 2 or grade 3. But it is a spinal reflex arc. It is not coming from the cortex. So you'll get a wrong impression.
Right.
So for upper motor neuron lesion, like a stroke like this, you have to volitionally tell the patient to move the lip. And, so you could instruct, it's not you, I know that, but you could instruct the houseman. Now it's very difficult to instruct everyone and to train them the way we want to see them. But I think we need to tell them, ki aisa pinching to nahi yaar, not acceptable. So these are the few of the points that I would like to make. It's unfortunate that, he didn't give you time. He deteriorated so much. And can you just show that picture post TPF, post this thing? Let us see that. No, that MRI. Yeah. Now, what is this? Is it an infarct or what?
So
this
DWI
infarct is
showing
there,
this is
but
infarct.
at the back,
This
in
is
the parieto-occipital
blades.
region.
This thing has blades, sir. Yeah.
Yeah, but ideally, he had improved, you said, no, clinically?
Yes, sir. Clinically, he has improved. Even though with this
so
MRI.
it is not a symptomatic hemorrhage.
Yes.
So, to diagnose symptomatic ICH, actually, we should do a CT scan. Because MRI will show SWI lesions, small punctate hemorrhages and all will show. But there is no deterioration in his NIHSS.
No.
In fact, his NIHSS has improved.
Yes.
So, these hemorrhagic conversions or what we call reperfusion injury may not be significant in these patients.
Right.
So, we get worried, Kyare Baba, there is blood in the brain. But actually, it may not be so important. So, ideally, post thrombolysis, we should do a CT scan. And if we see blood and blobs of blood, then, maybe we can say that it is a hemorrhagic or parenchymal hemorrhage. But, this MRI always confuses us. Hemorrhagic infarct, small things. Here it looks hemorrhagic, no doubt about that. But I think that it may have gone into the ventricle also a little bit.
Yes.
But did he have hemianopia?
Could not check, sir. He was on then BiPAP and then was
Yeah. Why was he on BiPAP? Because he had deteriorated.
He was not maintaining, sir. His ABG had
so
gone
maybe
down.
He got LVF, huh?
So PO2 deteriorated.
Yeah.
Creatinine shot up to 2. He was normal at admission. And he, HB had fallen from around 11 to 8. So there was rapid deterioration. Sir.
Yeah, very rapid. Huh? But, okay.
And even WBC count had gone like 27,000.
Yeah. Okay. So what would we have done differently in this case? What could we have done differently? Could we have done anything differently?
Shifting to higher center.
No, higher center mein kya karenge?
Yeah.
Maybe we could have done CT angio. And if there was LVO, we could have done thrombectomy. Maybe. And then, this cardiac thing, LVF had occurred. Yeah, I don't know. Some balloon pump or something like that. Or urgent surgery. Urgent surgery, can it be done?
They have advised urgent surgery, such cases.
Urgent yes. Mitral valve replacement.
Yeah. Yes.
Did they advise cardiologists?
They had advice, sir. But he, in 2 days, next 2 days, he expired.
Yeah. So maybe, if money is not short and all facilities are available, maybe we could have done that. But I don't know whether the result would have been different. And I would have looked for malignancy in this case. Yes. Maybe do CT abdomen, CT scan chest, and look for these markers of malignancy. How old was he, you said?
42, sir.
42. Yeah. So look for, this pancreas malignancy, notorious for producing thrombi like this. Ovary in females, yes, very common. But we could have looked for malignancy in this particular case. And, thinking, because there is no fever, it could be, Liebman Sachs endocarditis. So these things, is Anshul there? Anshu? He's not there, no?
No, sir. He is not.
Okay, so I have to do all the fielding. Okay, no problem. Okay, so Anuj, would you like to say something about this case?
No, sir, excellent. But the thing is, this is a common scenario. Echo, what could have been done in such scenarios? I mean, urgent echo.
Yeah, I know. If you are really super aggressive, and you have all the facilities, then maybe, I don't know, maybe mitral valve replacement on urgent basis.
Echo, if you have thrombus, I think thrombolysis would have been abundant because suspecting infective endocarditis.
Yeah, but you don't do the echo urgently, no?
Yeah.
I mean, that's not part of and it wastes time. So actually, it is not part of the protocol. So
yes, right.
Yeah, I know it's unfortunate. But anyway, very good case and well discussed, Venkatesh. We'll go on to the next case, Dr. Anuj.
Yes, sir.
Could you share your screen and this thing?
Yes. Yeah. Good evening, everyone. Without wasting time, I will directly go to my case. Yeah, in this 1 year, I thrombolized 26 cases. I will just highlight some bits of it. 2 bleed has expired. I mean, after thrombolysis, they had bleed and they expired. NIHS score was 23 in both of them. That one point I want to highlight. And 1 bleed after thrombolysis, we did craniotomy and now he's coming for follow and he's better, 4+/5 power. This last one case which are thrombolized through a hemiplegic hand, I will discuss this case in last. I mean, just what to do when I don't have any option for thrombolysis through a non-hemiplegic hand. So that part I will discuss later on. But the most important 4 or 5 cases, out of which I have selected only one case, which I'm going to present next. This is the recent case, and I have faced such scenarios 4 or 5 times, sir. So we'll discuss this case first. So recent one on 27 February, she is 55-year-old female, non-diabetic and hypertensive, presented with left-sided weakness in 6:30 a.m. He's a MRI technician, so he called me. He noticed that mother is having left side weakness. He called me. He was around 1.5 and 2 hours from Nasik. So I told him, you get MRI if possible and then come to hospital. So by the time they come hospital, it was 9:20 a.m. and she was little phobic. And so we could just got diffusion images. We could not get any other images, including MRI angio. NIHS score was 10. She was conscious, obeying command, human facial palsy was there, dysarthria was there, and left upper limb and lower limb power was 0/5. This was a diffusion image, just right frontal, she had an infarct, thrombolized. All reports were normal, only anemia, and that also he said it is a chronic anemia. So everything, echo also I got after obviously thrombolysis, which was normal. Thrombolized with 0.2 mg per kg, 13 milligram dose has been given. Everything was good, no issues. Next day, day 2, I got CT brain done after 24 hours, which was showing no emerging transformation. She was also improving well. Power has improved, upper limb 4/5, lower limb also 3/5. Till this time, I was God for them, but this CT was little scary for me because that has shown evolution. So that was little odd for me. With that point, I ordered low molecular heparin in such, this was the fourth case, sir. So I added low molecular heparin subcut OD along with routine double antiplatelets. Day 3, all good. Only this 6 to 8 hours, she had little BP fluctuations, that too around 110 to 150, which I got calls and also on recordings. This was the only thing happened on day 3. Otherwise, same status quo. Day 4, morning 8 a.m., she was conscious, but again, left upper limb, lower limb power was 0/5. Then situation got panicked. Immediately, I asked for repeat MRI. Repeat MRI was showing huge evolution, right frontotemporal, internal capsule, external capsule. Along with that, left also frontal infarct is there. MRI angio somehow we could do, but she was not again very cooperative. From MRI center itself, I shifted to higher center for DSA. We got her DSA done. DSA was showing left on right side distal ICA was blocked and MC and ACA was blocked. But on total occlusion is there on left ICA and there is no distal flow. This was the scenario and it was day 4. So aggressive medical management has been advised by intervention stroke specialist. Repeat echo I got, which was again normal. But I continued LOMO subcut BD for 3 days along with anti-edema. And then again OD for 2 days and I stopped with double antiplatelets. Last 2-3 follow-ups, facial has improved, dysarthria improved. Left upper limb, lower limb power is slowly improving, which is almost now 3+/5. So this is my case, but these are my points for discussion. What went wrong? I mean, MR angio not done probably because she was phobic and we were time bound. Mechanical thrombectomy also, I don't know. We don't have MR angio or something like that, so we could not do that. This point I want to discuss with you specifically, sir. This is the 4th case. Should we do CT after 12 hours? And should we add low molecular heparin? Because this is probably a recanalization thrombosis when we don't have specifically MR angio with us. Should we do that, sir? My case is over. I mean, this is just a protocol. Should we change or should I do something
No,
else?
why do you want to add after 12 hours? I mean,
this is
the recommendation is that for 24 hours not to give antiplatelet or heparin.
Absolutely. So,
and anyway, this dose what you're giving is for DVT prophylaxis.
Right, sir.
So what is it going to do? It's not going to do anything to the carotid artery.
Right, sir.
So it is this dose which is given and which is recommended is for DVT prophylaxis.
Absolutely.
So it is not a drug to be used for acute ischemic stroke, for the stroke per se. It is only for the DVT prophylaxis.
Right.
And no studies have shown any real benefit of giving heparin in acute cases, except some few rare cases of floating thrombus or dissection or something like that. But by and large, it has not shown to have benefit.
Absolutely.
So the low molecular weight heparin after 12 hours, no need. Now, another thing that, you cannot say that there has been progression because, see, MRI you have done in 2 hours, and many times you will not see the infarct fully in 2 hours in diffusion. Diffusion may take 3, 4, 5 hours also sometimes. So it is not a must that you should see. What you should see is a normal looking scan or a small infarct. And what CT scan you showed on 2nd or 3rd day and MRI on 3rd or 4th day or 5th day, they are more or less the same. So they have not added any further information. Now, what is intriguing is that, again, as I told you, any case with NIHSS of more than 6, any case actually you should do vascular imaging. Definitely if it is more than 6. But even if it is less than 6, you should do vascular imaging. Now, probably she had a large vessel occlusion involving the right carotid artery. And then I got a little confused because you said left was also thrombosed.
Yes, sir.
Did you say that?
Yes, sir. Left ICA is total occluded.
Yeah. Now, why do you need to do a DSA? This is another point.
I mean,
what advantage are you going to get by doing a DSA?
Nothing actually per se. But
then why do an invasive procedure for? I mean, when you're not doing intervention.
Right, sir.
If you are doing intervention, fine, perfect. You have to do. Now, you cannot do intervention without doing a DSA. But this is on the 3rd or 4th day. Which day? Fourth day. So 4th day, there is no advantage in doing DSA. You can do non-invasive imaging with MRI or CT angio if you have. Unfortunately, in our country, somehow this CT angio is not used much. Maybe the machines are not good. I don't know what the reason is. But it's a very easy test. Within 5 minutes, you can get information. You can get a flood of information with the CT angio, much more than with MR angio. And only thing is you have to give a dye. And, the patient has to be a little steady. But he has to be less steady, because it's done in 2 or 3 minutes. So it is much easier to do than MR angio, because MR angio, many times you have to sedate the patient or you have to tie the patient down, or, and many stroke patients are moving and they are restless. They are in altered sensorium. So CT angio, I think, should be done. It should have been done on day 1 only, or at the time of stroke. But okay, it was not available in the periphery, so I can accept that. But there is no advantage in doing a DSA on the 4th day.
Yeah,
that I think is not acceptable. Yeah. Acceptable in the sense it is not going to add value. And just a minute, I got a little confused with this. 1 second. What does it show? Total occlusion of distal ICA with no flow seen on right side. Okay, so there is distal ICA occlusion, persistent trigeminal artery with flow in BA and C. There's total occlusion of left ICA at origin with no distal flow. There is filling of through ophthalmic and ethmoid. So that means it was a chronic left ICA occlusion and a new occlusion of the right. Is that correct? My interpretation?
Yes.
So because there is good collateral flow through ethmoid and ophthalmic, that means those collaterals have opened up. So probably it has been a chronic occlusion there. And now there has been a fresh occlusion of the right distal MCA.
Right.
And that has produced the stroke. And the stroke is in the MCA territory. And as you said, a little bit in the ACA territory on the other side also, because that other side may also have been supplied by the right side.
Right.
So, in fact, is moderate in size. I think it is about 1/3 of the MCA. So, yeah, maybe it's not the full MCA. It's about 1/3 to 1/2 of the MCA. And, many times we have seen that this MRI shows this picture and we get scared and patients walk home and they recover. So many times I feel that this MRI misleads us. We see such a big lesion, but the patient improves. Just now I have one patient, he's my friend only. I saw, you see a big infarct like this, I got so scared, ki baapre, such a big infarct. And within 1 week, he started walking. He started going to work. The face improved. His hand is, of course, not improved. But many times, this the diffusion weighted image, it overestimates. And many times I feel that, we give a bad prognosis. But actually, in this case also, your case also, she has improved now to level 3. I mean, grade 3.
Yes, sir.
Is mobile?
With support, sir.
With support. So she is MRS about 3 to 4.
Right.
And it's only few days. So maybe, after 3 months, she may walk independently. You never know.
So LOMO, yes, I agree. It is a level C recommendation, but what anything else could have been done? Only dust double antiplatelets, nothing else?
No. The thing is, ideally here you should have done CT angio and done thrombectomy. But okay,
yes.
it was not possible. Okay. No, every time it's not possible.
Right.
I mean, facilities are not there. It's expensive. Intervention is not available. There are umpteen problems. So at least you have given tenecteplase, and I think you have done well for this patient. I don't think you can do anything more, and low molecular weight heparin is not really going to help. So after this stroke has occurred, patient needs good ICU care to prevent complications, to prevent hypoxia, infection, DVT, fever, bed sore, etc. And they do well, even though this MRI shows this ghastly looking picture. After 3 months, if you see, she may come back walking to you. So I'm very hopeful that she will do well. And we have found that tenecteplase is an effective drug for LVO also.
Yes.
Now, when distal ICA is involved, the chance of opening is only 6 to 10%. When MCA, M1, distal M1 is involved, or M2 is involved, chance of opening up is 33 to 40%. So it's a very, very effective drug. But only thing is that when it is a ICA now, the chance of opening is only 6 to 7%, or maybe 10% at the very most. So definitely you would need thrombectomy for these patients. And especially if they come in the window period. Here, I think we have to be aggressive with the thrombectomy. Because distal ICA to open up with IV therapy is very remote chance. It can, of course it can. We have shown some cases. Venkatesh, I think you had a case, no, last time. It can, not that it cannot, but the chances that it would become less and less, the more proximal the lesion is. The more distal the lesion is, the chances that it will open up with IVT are much more. So here I would have been aggressive in this and done vascular imaging and gone ahead.
Okay. And in my first slide, as I mentioned, sir, this was a very basic question, but still, thrombolysis from a hemiplegic hand. What do you think, sir? And I find no improvement in that patient.
I don't think there is anything like that. I was a little surprised but we like to give it from the hemiplegic hand.
You like to give?
Yes, why not?
Okay.
Because that hand is not moving, no? So you like to give it there. The other hand is moving. You have to tie down that hand. And that hand is moving and he's restless. So hemiplegic hand mein dene ka.
Okay.
So I would put a nice big, that green intracath.
Yeah.
Green intracath, that means 18 number in the hemiplegic hand.
Okay.
Because then, the chances of moving and coming out and getting the subcutaneous swelling and anyway, you're giving thrombolytic therapy. So, if it bleeds outside, then there's a big bloody headache. So
I'm correlating that with this, that there is no improvement because probably it have been gone through.
No. So don't worry. I think you put it in the hemiplegic hand. Okay. I don't think there's anything about hemiplegic and non-hemiplegic hand.
That's great.
Yeah, don't worry about that. And out of 26 cases, two expired. No, you said?
Expired, yes.
I think this, so that means into 4. 8%. 8, but they were bad cases. NIHS
Unfortunately, 2 expired at same center, so that physician.
Yeah. See, mortality is mortality after stroke, even in good centers, is 15 to 20%. And MCA occlusion mortality without treatment is 80%. With treatment, it comes down to, say, 20% or so. So your mortality is 8%, which is very good. So you have saved so many patients. So normative mortality would be about 15 to 20%. So you have halved the mortality by giving thrombolytic therapy. So congratulations, it's very good. 26 cases is a good number. Maybe you can make it 100 cases in 1 year. It's difficult, I know. I'm also struggling with that number, but we should do it, We should do it. We should develop our systems to do, because caseload is quite high and, we are just scratching the surface. So I think well done in this case.
Thank you.
Few points here and there, I think you can do fine tuning, and all of us are learning with this fine tuning. So there's nothing wrong. You have to be bold and present these cases. Every time we cannot present an optimal case, there's nothing like an optimal case. There's nothing like a standard case. Every case is different. Every case has challenges. Every case is unique. So it's very good that we are discussing all these cases. And there are problems, money is short, time is short, expertise sometimes is limited because it's in a peripheral hospital. So we have to overcome all these difficulties that we face, and we do our best. And I think your results are pretty good. 8% mortality is very good, I must say.
Thank you.
Of course, some will bleed, you
Yeah.
can't help it. But had you not thrombolized, you would have had mortality of 20%.
Sir, I had told your same statement to that physician.
Yeah.
Together in that stroke conference, you had told me.
So had you not thrombolized, you would have come here and said that out of 26 cases, 10 would have died,
Right.
or 8 would have died. So
I told
actually, we get scared about bleeding. We feel upset. We feel very upset. We can't sleep at night. And, कि ऐसा bleed हो गया और ऐसा हुआ, and, we get upset. But actually, if you see, if you analyze all the cases over a year or 2 years, you have done well.
Right.
You have done, because had you not thrombolized, these fellows would have done badly.
Right.
So though we feel bad कि ऐसा bleed हुआ, but if you see overall, for that family, of course, it is difficult. I'm not being, I don't want to be so hard-hearted, but looking at it from academic and, statistical point of view, it has benefited all those other 24 cases. So net, there is a benefit.
Right. And
this is not my data. This is data from all over the world. So net, there is a benefit. Yes, there are some bad cases. You can't win every single time. But this case, had you not thrombolized this case, and there is IC occlusion, the chances of mortality were also at 80%.
Right.
So, 80% chance that she would have died, and now she's walking with support. So you look at it in the broader sense, and actually you have done well. Yes, infarct is there. You cannot have a patient with no infarct, with MC occlusion. You can't have. So there will be an infarct, but she would have otherwise become bedridden. At least now she's walking. So she's not walking normally, but she may improve. We have time. 3 months is there. This is only 1 week or 10 days. 10 days we can't really judge. So with good rehab, this thing, she may improve.
Yes.
So I think I've talked too much.
Yes.
Ajinkya.
Yes, sir. Thank you so much.
Anshu is not there to give me support. I'm only doing all buck.
I think his connection was weak. That's why he couldn't join.
Yeah.
So with your permission, sir, we can stop here.
Yeah,
and,
we can stop.
It was
it's time, almost
actually,
time.
Yes. It was actually very wonderful and informative workshop, sir. And our online view count for today is 170. And I'm sure they must have been benefited from this today's session. And I would like to congratulate and thank you, Dr. Anush sir and Dr. Venkatesh sir, for presenting those interesting cases. And thank you so much, Dr. Ichapuria sir, for your expert comments and your great practical insights. And we would really like to work under your guidance, sir, for many such future programs. With this short note, we will close this session, sir. Thank you, everyone. Again, thank you for taking your time out from your busy evenings, and good night. Bye-bye.
Thank you, Anuj. Thank you, Venkatesh.
Thank you, sir.
For presenting good cases and to ignite the discussion. So, we learn by discussion only, and we learn from case to case. So don't feel upset if I pointed out any. It's not a flaw. It's just a different method of working. So, I mean, take it in the right spirit and get on with life. And Ajinkya, thank you once again for hosting this show. And I hope it has benefited at least few people in the world.
Yes, sir.
Okay.
Thank you so much.
Okay. Thank you.
Good night.
Thank you. Bye.